Further improvements in surgery actually are not going to improve the outcome of our patients, despite celiac access resection and other strategies or venous resections. Unlikely that a patient who progresses on neoadjuvant treatment would have been cured by upfront surgery, and we have enough good systemic treatment options. As you can see, the median survival, even with gemcitabine in the PRODIGE trial, was 35 months, and now for fit patients, modified FOLFIRINOX is the standard of care, the median overall survival being 55 months. The great advantage of neoadjuvant treatment is the great ability to administer systemic treatment without delay or concern about post-op complications. We can assess the drug sensitivity of tumor. We can select patients who are most likely to benefit from Whipple surgery, which is the most complex surgery that the patients have to undergo. The disadvantages with which I'm sure Dr. Sahu will talk about is that we require a preoperative biopsy, which we are not able to get in about 20 to 30% of patients, which is a challenge. We need biliary decompression and stent management in some patients. And of course, we could lose the window of opportunity for a curative operation. I think I liked this in this paper, which is recently published by the Japanese authors, that for the neoadjuvant selection, post-neoadjuvant, you may have insufficient recovery after neoadjuvant therapy or insufficient recovery after surgery for the patient to be eligible for adjuvant systemic treatment. And I think after having treated hundreds of patients, I can think of maybe 2 patients who were not eligible for surgery. One patient developed renal dysfunction and one patient had severe fatigue, but was actually able to get to surgery not immediately, but 2 months later. But insufficient recovery after surgery is very common. 50 to 60% of our patients do not get on to receive adjuvant systemic treatment after the surgery, and all of us are aware of that. This is an excellent pathology computational model, which actually shows that majority of pancreatic cancers are a priori metastatic. If you see this 2-centimeter tumor, which we rarely see in our clinical practice, even with a 2-centimeter tumor, there is a 70% chance that the patient has micrometastasis, which the conventional imaging is not going to pick up. This study very clearly showed that despite neoadjuvant therapy, there is no significant increase in complication rates post-neoadjuvant therapy. Just now, I'll go through a few papers which talk of the real evidence. So that's what we keep getting asked about. The PREOPANC was a study which randomized patients to surgery versus neoadjuvant therapy, which included GEM mainly, and chemoradiation as well. The primary endpoint of overall survival was not met, but it showed that the median disease-free survival and the metastasis-free interval was significantly longer for patients who had neoadjuvant therapy. But again, this study was underpowered. GEM is no longer standard of care, we know that, but it's an excellent drug in pancreatic cancer. It was muddied because it had chemo and radiation as well, and included borderline resectable patients as well. This Japanese study also tried to look at the same question, and you can see that the patients who had neoadjuvant therapy had a significantly longer 37-month median overall survival versus those who had upfront surgery. There are two meta-analysis which I'm going to talk about, which actually showed, this is a Markov decision analysis, which looked at life expectancy and quality adjusted life years and compared neoadjuvant therapy versus upfront surgery. And neoadjuvant strategy resulted in longer life by 32 versus 27 months and a higher QALY as well. This was a 3:1 propensity score matched analysis, and a huge number of patients from the National Cancer Database, and it showed that neoadjuvant treatment led to a downstaging in T, lymph node, and resection margins, and the overall survival was significantly better for those who had a neoadjuvant treatment compared to surgery alone versus surgery plus adjuvant therapy. The other thing which is quite exciting for patients who have neoadjuvant therapy in potentially resectable cancers as well, that a decrease or a drop in CA 19-9 gives us a very good indication of whether we should change treatment and try and get the patients to a response. As you can see, patients who have a major pathologic response do significantly better compared to those who have a partial or a minor response. The core argument has always been we need randomized data. Upfront surgery has become standard of care without randomized data. It is difficult to accrue to such a trial, we know that. And though there is an alliance trial which is running, which is randomizing patients to upfront surgery followed by adjuvant treatment versus neoadjuvant treatment, which includes chemotherapy followed by chemoradiotherapy as well. I think we have used this approach in many other tumors like esophagus, stomach, and rectum, which have actually become standard of care. In rectum as well, we are moving towards total neoadjuvant therapy. I think to conclude, given the evidence we have and knowing that pancreatic cancer is a systemic patients, the debate should be what regimen should we use. Should we use chemotherapy or should we use chemoradiotherapy? What strategy we should use, when we should operate, whether we should give the treatment for 2 months or 3 months, whether we should aim for a pathological complete response. The first patient I had a PAT-CR in pancreatic cancer, we gave gemcisplatin with the BRCA mutated patient. So I think upfront surgery followed by adjuvant treatment is a failed strategy. 90-day mortality remains high. R1 resection rates are frequent with the new protocol. And about 20% patients have unnecessary surgery because they recur very, very rapidly. And only 50 to 60% of patients we know are able to complete adjuvant therapy, and their survival has remained stationary over the last 3 decades. Thank you.
And thank you, Bhavana, for the wonderful talk. And we have now a second speaker, Dr. T.P. Sahu from Bhopal. So he'll be talking on adjuvant treatment in operable pancreatic cancer. Dr. Sahu, please.
Okay, so I'm audible?
Yes.
My screen is sharing.
Yeah.
Yeah, thank you. Thank you, Bhavna. The only difference between a surgeon and a medical oncologist will be when 2 persons of the same tribe come together, there's a fight. So that's what it happens. So that will be the difference. The flavor will be slightly different. And I know I'm debating against a stalwart who does predominant work in breast, female cancers, and GI. So keeping that in mind, so let's see who wins the debate. And I think the last slide should be just taken off as the Lok Sabha speaker tells, just take this out of the record. So neoadjuvant chemotherapy for all, my answer is a big no. And I will tell you in my next 10 minutes allotted to me why it should be and what's the evidence. We know the slides that we have moved from observation post-surgery to gemcitabine alone, then the combination of gem and capcitabine, then came this big Japanese trial. And I want Bhavna, he knows this trial, keep the watch on the S1 5-year survival. The median OS of 46.5 will come down when we debate this back. So this is what happened to the adjuvant S1 versus gem. And this is the trial all of us know has spoken to the well-preserved GC. This is the drug to go back to the modified FOLFIRINOX, which has the highest ever survival of 54.4 months. The debate was, do we give neoadjuvant chemotherapy in an operable pancreatic cancer? And I would just like everyone to get into the definitions of a resectable. That debate was about resectable pancreatic cancer. The resectable means anything that is not in contact with the vessel broadly, or if there is some, that is without any contour irregularity. So nothing beyond the borderline resectables go away, the locally advanced go away, because the debate was about resectable. So why should I not go for surgery? Why should anyone waste time with a neoadjuvant treatment at all? The word is waste time. That's more important. Need for biopsy. She herself told it that 20% you would not get a biopsy. That's something that is a drawback. Potential complication of pre-treatment procedures. What would you say to one of the near and dear whom you would lose, that rare patient? Very rare, but you might, and the trials have proven it. That patient, you have nothing to say to the relatives. This is a big trial that came in the New England Journal, the biliary stenting morbidity. Expectedly, head of pancreas, the most common tumor, you would have obstructive jaundice. And when you have obstructive jaundice, if you're going for neoadjuvant approach, you would go for a prosthetic stent. And look at it. If you go for a stent in a randomized way of 200 patients, the article from NHM clearly states you have actually doubling of the preoperative complications. That is 39 versus 74. And the surgery, whenever it happened, also these patients did do very bad. There was more of complications. So this is what happens when you do neoadjuvant chemotherapy. So come back and look at it. There is a disease progression across data. If you look at it for the last 15 years, that the data is evolving, but whatever data is we have in published domain, there is a good amount of patients who do not go on for surgery, and a good chunk of that is due to progression of disease before surgery. So why at all do that? Is it worth it? Do we have the data to prove that I do so much and there's something which I achieve for my patients? So why no to neoadjuvant? No robust evidence, no large prospective randomized phase 3 looking at the OS benefit, except for the Japanese. We'll come down to that, why Japanese should not be collaborative with the world. We have seen in ovary, we have seen in stomach, we have seen across, they are very different. Should we be looking at them, and the worldwide, should we be accepting the Japanese study? Likely difficult to show the OS advantage. As I told you, you would like to avoid any incident that could be bad. So coming down to evidence, why you should not be doing it. Look at this benefit and look at this meta-analysis looking at upfront surgery versus neoadjuvant. One of the systemic review published in 2018. And if you look at it, they looked across the survivals. Ultimately, all of us want survival. And if you look, the upper one is upfront surgery, then the lower part is the neoadjuvant. And if you get the whole things up, the quality of all the data that has been in neoadjuvant predominantly are very small. Most of them retrospective. Very few patients. The one of the few early trials, 2 or 3, could not complete the accrual. They were so difficult, which Dr. Bhavna also alluded to. So basically, we do not have any large evidence which is high quality, except for one which we will come down to. And if you look at it, this is the numbers. You look at the numbers, it's in double digits. That's how the trials have been. But look at it. When you have adjuvant, you have FOLFIRINOX, you have GemCap, you have survival jumps. And we have the highest survival ever recorded, crossing an overall survival of 54 point median survival. That is with the adjuvant FOLFIRINOX modified. Now, this trial was very quickly told by her. I'll go into the fine prints. It's beautiful to read the paper, but also go to the fine prints what the paper reads through. If you look at this, it was a randomized trial with all its fallacies. It was a pre-chemo radiotherapy versus immediate surgery. Gem radiotherapy followed by a surgery or adjuvant gem. And this had patients who were resectable and who were borderline resectable. And 55% of patients were resectable, as I told by the definition. It did not meet the primary endpoint, which is rightfully told. The OS was not superior. And it was, but this is the beauty of this paper. If you go through this, they divided the resectable pancreatic and the borderline resectable. Now look on the left-hand side and the right-hand side. Look at this. When you have a resectable pancreatic cancer, 133 of the patient lot, and you have randomized them, there's a numerical survival advantage to the arm which has received immediate surgery. And go up to that borderline where neoadjuvant chemotherapy works better. Go down to the resection rates. This is the beauty of every paper of neoadjuvant chemotherapy. Around 30 to 40% patients across trials do not end up with surgery for whatever reasons. For progression, because they withdrew consent. But in a real life scenario, this is the truth that out of this 44 out of 65 went ahead and operated in the operative chemotherapy, while 80% of the patients in surgery first went out to get a surgery. Final, patients with all grades have toxicity and more with the neoadjuvant chemotherapy. So here, in the resectable group, which was we were given to debate, we have no difference in the OS. Actually, numerical superior OS in the upfront surgery. We have a higher risk persons going ahead for surgery. We have more dropouts in the patients who had pre-op chemotherapy, and the advantage of this all whatever it was not there. To add on to that, you add on the toxicity. So, of the 119 patients to the neoadjuvant arm, only 72 underwent dissection. A huge 40%, 50%, 50 patients could not undergo resection. And this is across trials, not only this Dutch trial. And if you go across, go 10 years back, there's a publication telling you that 27% do not undergo resection. And even the NCCN tells that there is large paper data where 25 to 30% of patients are found to have progressive disease, so they are not able to operate. Now, the conclusion of that paper, it did not show a OS benefit. Now, coming down to the Japanese, this is the JSAP 05, and look at it. The neoadjuvant had the 36.7 overall OS median, and the upfront was 26.7. It was much higher than what the Dutch showed, but the applicability to this data to other populations is a subject of debate. We have seen that happening in the weekly Pacley carbo for ovary. We have seen this across subject. The Japanese are different. Their data is never ever cross-matched with any other population data. Compare this with the survival of Dutch trial, which was just we showed. Peep into the survival of Dr. Bhavna. The JSAP 01 with the adjuvant S1 had a median survival of 46.5 months, where this trial showed at 26.7 months. And this is something which the data have to be answered, because these both trial subsets were from the Japan, and that cannot be told that they were different population. No, and last, we need to read the full text. I need to go to the whole publication, because a lot more goes beyond the abstract which they put up in the ASCO. Now look at this. This is a very beautiful thing to correlate. Look at the meta-analysis. If you go for per protocol, means patient who go for chemotherapy, who get operated, who get the adjuvant chemotherapy, then there is little difference towards shift towards the neoadjuvant. But if you go to intent to treat population, means every person who is randomized and taken up for the trial, the benefit is lost. There is no benefit of neoadjuvant, and that's what the patient is when they sit in front of you. You do not know what is going to happen to them. So you have to go as per the intent to treat population, not as per protocol. And second last, the one trial majorly for the per patient protocol, this was the trial which Dr. Bhavna alluded to, contributed to 76% of the weightage of the neoadjuvant study. 76%. And this is the MOGDAT data of JCO, which you rightly alluded to. But the point is, which you did not tell, it was a data which was an observational study, not a randomized, huge data set, but there are fallacies, and to attribute 76% of the weightage to a subject up to a meta-analysis and just take that out, and the neoadjuvant chemotherapy loses its sheen. The whole thing falls flat when that whole data is taken back. So that is what happens when you just put forward a data which is not the best possible evidence, and when you take it out, it falls flat. Second, look at the resection margin which you alluded to. I'll go to a randomized trial published in JAMA Surgery, 2008. I could not find a randomized controlled trials meta-analysis which looked at it. There is no difference in OS, irrespective of margins, but I do concede there have been data where the margins do play a role. That's there. But the OS benefit is there, something which to be seen, but on a meta-analysis, it is difficult. Last, fine points of NCCN points very clearly that although data is not strong, but there is data that delay in initiation of adjuvant chemotherapy in pancreatic cancer has not impacted the outcome. And this is data which has been put up in the NCCN fine prints. And look at this network meta-analysis, where part of which he told, but look at the post-operative complication and neoadjuvant chemotherapy scores in that big brown graph. And this is where the green one is upfront surgery. So, let's go to guidelines. Everything is said. I've proven everything. Now go to the last two slides and the guidelines. NCCN 2021, not 20, Dr. Bhavna. Look up. And that 21 tells you that you proceed to surgery without neoadjuvant chemotherapy, except for selected patients who have very high CA 19.9 pin or very high bulky disease. That's when otherwise proceed to surgery is the way to go ahead. ESMO told that few years back. And if you look at the fine prints, at this time, the panel does not recommend neoadjuvant therapy for clearly resectable patients. So, to conclude, you take 100 patients of resectable pancreas, 20 to 30 will never get operated, as I showed in the randomized trials. Add to that the morbidity, which is well proven across trials, and the rare mortality which can happen because of neoadjuvant chemotherapy. And in a resected pancreatic cancer, no high-level evidence of OS advantage with the neoadjuvant therapy. Why do you even consider this, Dr. Bhavna? Be fair. You have been a very rational person. I've seen you speak. I've heard you speak. But somehow, just for a debate, don't change the way you are. And this is what it is. Why do you want to consider to just add to toxicity? And if that is your primary endpoint, then I concede this debate rightly. So, the only thing I can give you at this point is it's an emerging concern. In the resectable cancer, in the locally advanced, in the borderline, it is a concept to deal with. So, last few words from a person who has learned a lot from you. You were born with the greatest weapon of all natures, all of us, and that is a rational, conscious mind. So, mistakes become less when rationality thinking precedes all action. So, I hope on a rational mind, all of us will not give neoadjuvant chemotherapy to the operable pancreatic cancers or resectable pancreatic cancer, and we will just go with upfront surgery and give adjuvant chemotherapy, because the survival of 55 months is never heard of in any pancreatic cancer protocol. So with that, I rest my case, and I hope Dr. Bhavna now changes her mind and speaks. We will not give neoadjuvant. Thank you.
Thank you, TP Sahu, for keeping your words so strong. Now over to you, Dr. Biraj, for your comment.
Can I rebut Rivara?
Yes, madam. I was just going to say, madam, because I am in the team A who does preoperative treatment for all pancreatic cancer. So I would want you to say a few words.
So I think, Tarini, exactly as you said, I am very, very passionate about this subject. In fact, I would refuse to debate for upfront surgery even if I was given the chance. Because, you yourself have said 55 months overall survival. Where have we seen that in pancreas? Surgery is a very important component. I completely agree. But what has changed the treatment what has changed the outcome in the last 30 years? I mean, when I started training in early 90s to now, is modified FOLFIRINOX. I came back from ASCO and I was attending Friday MDT with Professor Cunningham, and we said, the next patient will get adjuvant FOLFIRINOX without even looking at the full paper. The data was so impressive. So why not, we know 50% of our patients will never get to that. In fact, 60% of patients in some settings, in trial settings. In real world, we have more number of patients with leaks, with pancreatic insufficiency, with failure to thrive after a Whipple's. They never get to modified FOLFIRINOX. They end up having GEM or nothing, and definitely not for 6 months. So I think we have to bring it forward, give the systemic treatment before. We have to do what is best for our patients. And for that, I'm really passionate about. The other thing is, Whipple's is not like breast cancer surgery, where when a patient is progressing, we say, in neoadjuvant, the patient should go for surgery. Whipple's surgery itself carries a mortality of about 20%, and we don't have service reconfiguration in India. So in UK, unless you are doing 20 pancreas a year, you are not allowed to touch a pancreas. Here, we are working with people who are doing 5 a year, 10 a year. We have to try and do what is best for our patients. For the 20% who are progressing, do not need a Whipple's by somebody who's doing 5 a year or 10 a year. So do you agree? I think you would agree. If I had the choice, I would take systemic first.
That's true, but I feel that data at this point, to be fair to all of us, is definitely going towards the neoadjuvant scenario. But for the really resectable, I feel there's a strong case for
upfront. There's no data for surgery. We won't do a parachute trial. I mean, that's the only analogy I can think of.
What we did was for a debate, and at this point, the resectable cases, I think, should get both the choices for borderline resectable. The point what I feel in the clinics is people do not differentiate between a resectable and a borderline resectable.
That's very important.
Yes. If that is missed, then I think the whole charm of the debate or any discussion patient goes.
Yes, absolutely. I completely agree. Wonderful presentation. I really enjoyed it.
Thank you.
Thank you, Dr. Bhavna and Dr. Sahu. It was an excellent presentation. Very nice debate. Move on to the next session. The next session is from AstraZeneca, and we want to discuss the maintenance strategies in pancreatic cancer. Let me welcome Dr. Chu Su Pin from Singapore. She's a medical oncologist and head and director at Singapore University. Madam, welcome. Good evening.
Hi, hello everyone. Thank you so much for the honor of being able to share tonight at this session, and thank you very much, Dr. Vinit and Viraj, for inviting me here, as well as AstraZeneca. And I did enjoy that debate, Dr. Valna and Dr. Sahu. We can go on and on about that, but I think I need to move on to maintenance therapy in BRCA-positive pancreatic cancers, with a focus obviously on looking at PARP inhibitors. And these are my disclosures. So as the previous speakers have mentioned, pancreatic cancer is a very difficult to treat disease. And majority of our pancreas cancers, up to 80%, present in the advanced unresectable state. And even with resection, we'd say about 5-year survival is only about 20%. Okay, so our cure rate is very, very low, and it's a leading cause of cancer deaths. And without any treatment, we are talking about a median survival of about 3 months. Okay, though I think these numbers should increase with effective therapies that we have nowadays. Yeah. So consistent across all countries, pancreatic cancers tend to are diagnosed at stage 4. Okay, and we now have a pretty well-defined first-line chemotherapy for advanced pancreatic cancer, which would be FOLFIRINOX from the PORTIDGE 4 study, which showed better survival benefit as well as PSF benefit over gemcitabine alone in the first-line setting. And then we also have gemcitabine, nab-paclitaxel, which was also shown in the MPACT trial together and gemcitabine alone in the first-line setting, both for OS and PFS. Okay. So with these two, new combination drugs, which we use interchangeably, we're hitting median OS of more than a year. Okay. So we also have phase 3 data in the second-line setting after gem-based therapy, and that comes from the Napoli study, which used liposomal irinotecan in the form together 5-FU, similar to the FOLFIRI, but using liposomal irinotecan, and this was shown to have OS benefit compared to just 5-FU alone. So we go straight into the NCCN recommendations for second-line therapy for both locally advanced as well as metastatic PDAC. And assuming good performance, we would usually use, if you have prior gemcitabine-based therapy, we would use 5-FU-based. If you have prior fluoropyrimidine-based therapy, then you would switch to gem-based. But specific in blue here, we would, if you are a BRCA mutant or PALB B2 mutant tumor, then we would recommend a platinum-based chemotherapy, which in this case, if you had fluoropyrimidine before, then gemcitabine cisplatin would be recommended. Yeah. And then special circumstances, there's the MSI high, which is actually very rare in pancreatic cancers, less than 1%. You consider anti-PD-1. The ESMO guidelines do not specify, are not so specific. Any of the ESMO guidelines probably need to be updated. Haven't been done for a while. And essentially, the other and second, they do in patients with gem refractory tumors, 5-FU, FOLFOX. They did say that they were still FOLFOX would extend OS compared to just 5-FU alone. But I think their guidelines would be updated in time. Okay. A series in terms of the targetable targets in pancreatic cancer, right? They're actually it's the mutational landscape. The most common mutation would be KRAS. About up to 70% would have somatic DNA repair changes, alterations. But largely, if you look through all the different mutations and so on within the in pancreatic cancer, most of them are not quite targetable at this point in time. Though there are many studies targeting KRAS mutation. We know of the specific KRAS inhibitors for G12C, but G12C is actually very, very rare in pancreatic cancer. It's more common in lung and colorectal. Okay, but I'm sure people are developing drugs, and it's a matter of time before we are able to apply precision medicine to pancreatic cancer. So this just shows you the PDAC and MSI high, where just we know it's very, very rare. Okay, in our own population, it's really less than 1%, and usually they're responsive to checkpoint inhibitors. A response rate of about 60%, depending on which study you look at. Okay, so straight to BRCA1/2 mutations in pancreatic cancer. This about 5 to 7% of patients with pancreatic cancer have germline BRCA1/2 mutations. More common in Ashkenazi Jews and families with familial pancreatic cancer, as well as familial breast ovarian cancer. Okay, 40% of pancreatic patients who have germline BRCA1/2 mutation carriers do not have a family history of breast ovarian cancer. So we have to keep that in mind. So based on current NCCN guidelines, it is recommended that all newly diagnosed pancreatic cancers, irrespective of the family history, should do germline testing and genetic using comprehensive gene panels. Genetic counseling is also recommended for patients who test positive for pathogenic mutation or for patients who have positive family history of cancer. And they also recommend somatic gene profiling for all advanced disease. Okay, looking for actionable mutations. Obviously, we usually look for, everyone's looking for track fusions and so on, though they're rare. And for us, we always try and look for mutations and try and allocate patients to clinical trials. Okay, the genetic risk evaluation is also recommended for any individual diagnosed with pancreatic cancer, and that's why we do have a genetics clinic to address that issue. ESCO now also recommends genetic testing for pancreatic cancer as well. Similarly, as well as you know that the patients with BRCA1/2 or PALB2 mutations are at 2 to 7-fold increased risk of developing pancreatic cancer. Okay. So if we just focus on BRCA mutant, germline BRCA mutant, PDACs, do they do better or worse? The prognostic value of being germline BRCA mutant remains unclear. There's studies that show that they have superior OS and studies that do not show that they have superior OS, so this is not very clear at this point in time. However, we know from evidence that BRCA mutants, pancreatic cancers, having a BRCA mutation is predictive of better outcomes with platinum-based therapy, and that makes sense scientifically as well. The OS by platinum therapy for germline BRCA mutant pancreatic cancers, when given platinum, is much higher than if you are given non-platinum. Okay. And the rationale for this is because platinum causes DNA damage, and you know that in BRCA mutant pancreatic cancers, they have HR deficient cells, and they will have enhanced sensitivity to platinum therapy. The NCCN recommends thus for germline BRCA mutant patients with good performance status that they should receive platinum-based chemo as the preferred first-line therapy, whether it's in the form of FOLFIRINOX or gemcitabine plus cisplatin. Okay. And if patients have good performance status and respond and do not progress on the platinum therapy, then PARP inhibitors like olaparib should be considered as maintenance therapy, okay, which I'll get to in a bit. So PARP inhibition, we know, is used in other cancers or prior to its use in pancreatic cancer. PARP is critical for DNA repair, right? And when there is a deficiency in HRR and cancer cells with mutations in BRCA who have defective HRR function, right? The treatment with PARP inhibitors will cause DNA breaks and lead to cancer cell death. Yeah. So we know from other cancers, in phase 2 studies, that patients with pancreatic cancer and have BRCA mutations had promising responses to PARP, whether it was the rucaparib, olaparib, or rucaparib as maintenance therapy. Okay. In ovarian cancer, there have been multiple clinical trials, and we've shown consistent benefit of maintenance PARP inhibitor in BRCA mutant ovarian cancers. So this led to POLO, which is the first phase 3 trial to investigate a PARP inhibitor in patients with germline BRCA mutant pancreatic cancer. This was a double-blind study in patients who had metastatic pancreatic adenocarcinoma, who had germline BRCA mutation, were PS of 0 to 1. The key point is that they had 16 weeks at least of first-line platinum-based chemotherapy and did not show any evidence of disease progression. Okay, and then they randomized to receive either olaparib with a 3:2 randomization or placebo, and the primary endpoint in this trial was progression-free survival. And secondary endpoints were OS, PFS2, and so on. So from the POLO, there are, I think, 2,206 patients were screened, of which final 7.2%, 159 patients, had germline BRCA mutation. And they found, if you look at the distribution, it's not unexpected. Highest prevalence of BRCA mutation was in US, Israel, and France. So these are baseline characteristics of the trial, the olaparib arm and placebo. They were generally well balanced. There were more BRCA2s as expected with pancreatic cancer than BRCA1s. Pretty balanced between male and females. Majority are ECOG 0. And in terms of duration of first-line chemo before entering the trial, median duration was about 5 months. Okay. Liver mets was the most common site of metastasis. And in terms of previous chemo, majority had FOLFIRINOX, which is not surprising, and only a small proportion had gem cisplatin. Median time from diagnosis to randomization was about 7 months. Okay. So over 30% of patients on olaparib were still ongoing study at time of data cut off. So if you look at the most common reason for treatment discontinuation was disease progression in about 50% of 50% of the patients in olaparib and about 60% of patients in the placebo arm. So this was the primary endpoint, and the patients were maintained on olaparib had significantly improved PFS, 7.4 months, compared to placebo, which was 3.8 months, which is about double. Okay, and basically olaparib reduced the risk of death or progression by 47% compared to placebo. The PFS benefits was seen across all pre-specified subgroups. OS not mature, but so far the median OS in olaparib was about 18.9 months. 23% of the patients at baseline had a response to olaparib treatment. The base compared to placebo was only 11.5%, and disease control rate was 53%. Compared to 37% in placebo arm, and significantly the median duration of response from onset of response was 24 months in the olaparib arm compared to just 3.7 in the placebo arm. Most patients also went on to receive subsequent therapy after end of study treatment. As you can see here. There was also, if you look at PFS2, which was the secondary endpoint, there was also a trend towards benefit, though this was still not statistically significant. So this summary of the endpoints, specifically the PFS, which was the primary endpoint, was significant. And there's a trend towards PFS2 as well as OS benefit. What's most important about PARP inhibitors is the quality of life. We all know that FOLFIRINOX is a tough regimen, but if you look at the QOL over time, was pretty good with olaparib, and as it was comparable to the placebo arm. Okay, and in terms of adverse events, they were generally mild or moderate to olaparib. Any AE leading to discontinuation of treatment was only happened in about 5% of patients, okay, which is here as well. Those reductions and those interruptions occurred in those interruptions was 35%, those reductions in 16% of patients. So in terms of side effects from olaparib, it's no different from what we see in other cancers. Generally, it's very easy to tolerate. The main thing is fatigue, and in this study, only fatigue resulted in treatment discontinuation for more than one patient. Otherwise, the other reasons for discontinuation are listed here, and there's very small numbers. Okay. So the rest of the AEs would be nausea, some diarrhea, some decreased appetite, and generally very mild. Very few are actually grade 3 or greater. AEs of special interest were in line with rates seen in previous trials of olaparib. Specifically, there was only one non-serious event of olaparib. The new pairing malignancies are not unexpected in this population of patients. So this gives you a illustrative summary of first-line treatment, and the gain of 7.4 months just on maintenance olaparib. And this is currently the only phase 3 data for PARP inhibitor and PDAC, though there are other studies ongoing with other PARP inhibitors from other companies as well. This is just a list of other PARP inhibitors that have been tested in BRCA mutant cancers. Some include pancreatic cancers, and some, but they are not purely pancreatic cancer trials. So, in summary, germline testing for BRCA is recommended for any patient with confirmed pancreatic cancer, and really genetic risk evaluation is really recommended for all pancreatic cancer patients. PARP inhibitor maintenance following platinum therapy significantly improves PFS in patients with germline mutated metastatic PDAC compared to placebo, and is a new standard in the treatment of advanced pancreatic cancer with a PFS improvement of 3.6 months compared to placebo. Twice as many patients were progression-free following olaparib treatment compared to placebo at the time points assessed. 22.1% of patients were progression-free at 2 years on the olaparib arm compared to only 9.6% in the placebo arm. And safety findings in POLO trial were consistent with what we know of olaparib in other cancers, with the most common AEs being nausea, fatigue, and anemia. But the treatment of pancreatic cancer will continue to evolve, as I believe precision medicine will play an increasing role, and we should if where possible, we should routinely offer the option of gene profiling to all of our advanced pancreatic cancer patients. With this, I thank you very much. Thank you.
Thank you, Dr. Chu. That was a fantastic talk on maintenance. I had a question. Since we are running short of time, we'll just take one or two questions. I had a question. Have you used the single agent capecitabine chemo as maintenance in pancreatic cancer after, let's say, FOLFIRINOX or gem/nab-paclitaxel?
Pancreas tends to be very aggressive, so I tend not to use maintenance because they invariably progress. And when they progress, they become too sick. And you've lost that window opportunity to treat. But saying that, obviously there are cases where patients have not tolerated treatment well, and you want to drop some of the chemo drugs, and yet you don't want to give nothing, but you do tell a patient the chance of this working is only X%, it's very low, and in those cases I would give just Xeloda or single agent 5-FU alone. But it's not common. I think pancreatic cancer, there's really no data and no role for maintenance therapy except for PARP inhibitors in the germline mutated. Otherwise, they invariably will progress. Yeah.
So, if I get it correctly, it's the treatment until progression, or just a holiday if somebody wants to just take a break, but no maintenance strategy per se. Is that what the message I'm getting?
Yes.
The patient is non-BF.
Yeah. Okay. So it's a more a break from the toxicities of combination chemo.
Right. Thank you, Dr. Chu. Can I have right, Dr. Sana Al Sukun from Jordan to have her expert comments? Do we have Dr. Sana?
Yes. Hi. Good evening.
Hi. Good evening.
Greetings from Jordan, and hope everyone is doing great and safe, hopefully, in India. I enjoyed actually the talk and the debate, and it has been very informative. Just to recap, number one, pancreatic cancer is soon to become the second leading cause of actually cancer deaths worldwide in the next 10 years or so, as predicted by the WHO. Can you imagine? It would be the second leading cause of cancer-related deaths worldwide. And there is an increasing incidence related probably to obesity, smoking, and other environmental factors we cannot really much dissect, at least so far, but it is predicted to increase with the increasing incidence. One thing we have learned that staging is quite important to determine resectability versus inoperability, but unfortunately most patients present with advanced stage disease. And here is the challenge. Let me start by the advanced stage disease. Quick reminder that histopathologic criteria do not adequately inform treatment decisions for pancreatic cancer. Indeed, so far, as clinicians, we have noticed in our clinics, despite the fact that we have always learned that 5% barely of patients with advanced pancreatic cancer would survive the 5 years, we have seen patients surviving 3 and 4 years, and we have seen patients not surviving 3 and 4 weeks. And lately we have learned that there are at least 4 molecular subtypes with strong overlap. Only 2 have been represented in every single study, the epithelial classical and mesenchymal basal-like subtype. However, there are other subtypes that have not been well represented and sometimes tend to do really well. Until we get to be able to classify our pancreatic cancer patients, at least for the sake of prognosis according to these subtypes, what we have been using in clinic is finally the standard of practice FOLFIRINOX for patients with performance. Hello?
Yeah, please go ahead, Dr. Sana.
we have the standard of care until we dissect, at least for prognosis, these 4 subtypes. Our patients with good performance status, they deserve a shot at FOLFIRINOX, and particularly the modified FOLFIRINOX without the bolus 5-fluorouracil, because it is much more tolerable. And if they have a performance status that is compromised or they're elderly, gemcitabine and nab-paclitaxel comes into play. Single agent gemcitabine after progression on FOLFIRINOX and gemcitabine and nab-paclitaxel is a possibility, and so is capecitabine, not in the form of maintenance, but indeed in the form of a second and third line. For those patients who have tolerated therapy, first line and second line, and soon to be available, the pegylated irinotecan has really promising activity in patients with advanced pancreatic cancer. Something to keep in mind, again to remind, modified FOLFIRINOX is much more tolerable as compared to FOLFIRINOX, and among patients who really cannot tolerate irinotecan, FOLFOX has at least in phase 2 trials, promising activity. Now, moving to the early stage disease, that limited proportion of our patients that present with localized disease, operable versus inoperable, and I enjoyed the debate between, giving neoadjuvant versus adjuvant. And hopefully the trial that is ongoing right now in the US just started will answer this question for good. If your patient does not have arterial involvement, 3 months and borderline resectable because of venous involvement, because of, all the criteria that has been mentioned earlier, definitely 2 months of neoadjuvant therapy without metastasis and revisiting by a surgeon with experience and high volume disease experience deserves a shot. Surgery still standard of care for patients who are resectable, unless there is arterial involvement, needs somebody with special experience to handle that particular subset of patients because they really have compromised outcome after surgical intervention. Whether to use, you have discussed this in details, FOLFIRINOX or gemcitabine nab-paclitaxel after their most recent data. Again, I don't think the most recent data said gemcitabine nab-paclitaxel is a bad option for adjuvant therapy. I think it only said if your patient can tolerate the FOLFIRINOX, go for it. If they can't, go for the gemcitabine nab-paclitaxel, because after all, if your patient doesn't get the treatment, it will not be beneficial. So we have to choose what's tolerable for our patients. A final word to say, genomic studies and cooperation at international level would be the only way to inform our treatment decisions and improve the outcome for our patients. Patients with pancreatic cancer so far do not benefit from the regular use of checkpoint inhibitors. Ongoing trials for immune therapy are in place, but not for the checkpoint inhibitors, cell-mediated immune therapy, vaccines, and etc. But so far, we do not have solid, encouraging data. We do have encouraging data, but not really solid. I believe for pancreatic cancer, similar to what Dr. Raj, I think, just discussed, the BRCA mutation opened the door for using PARP inhibitors as a proof of concept. When you have an actionable mutation and you use the proper targeted therapy, you make a huge difference. But that's a very minute proportion of our patients. If we could share, and this is an excellent platform for us to work together, I wish we could indeed share data about genomic studies done for our patients with pancreatic cancer and see what are the common mutations, because they are among the most challenging tumors with the least possibility to have actionable mutations. Let's see what are the most commonly found actionable or potentially actionable mutations and share experience between our patient populations. I think this is how we can advance the field for pancreatic cancer. But so far, all we have is a FOLFIRINOX regimen, a gemcitabine nab-paclitaxel, and pegylated irinotecan. Whether early or advanced, Those are our options, plus best supportive care. And thank you for the invitation to share with this great ensemble of experts.
Thank you, Dr. Sana. That was a nice summary of metastatic pancreatic cancer. To go ahead, we have a panel discussion moderated by me. That's Viraj Lavingya. I'm a medical oncologist in gastrointestinal oncology at Ahmedabad HCG. And I have 4 panelists today: Dr. Bharat Vaswani, Dr. Krupa Shankar, Dr. Smita Kayal, and I would also like to have Dr. Crystal Denlinger from Philadelphia join me. Dr. Crystal, you there still with us?
I am. I have a meeting at 10:30 my time, but I can join for the next 10 minutes or so. Sorry.
All right. So organizers have told me that I have to cut short this panel discussion for 15 minutes. So we're going to just wrap it. I just have one slide and we want to discuss this case. Next slide, please, would be. So I have a couple of questions jotted down. Next slide should be. Next slide. Next slide. One more back, please. Okay, so this is the case. This is the standard case that we see. 47 male. Go in front, please. Next slide, please.
Yes, I think you have the correct slide finally.
Yeah, this is the correct slide. Stay on this slide for the whole session. Okay, so 47-year-old male presenting with diffuse, vague, intermittent abdominal pain for last 2 months. He started to lose weight, about 4 kilos in last 2 months, and has developed anorexia. Very recently, since last 3 days, he has started developing vomiting for all solid meals. On examination, he had PS of 2 and had icterus jaundice. A CAT scan showed a locally advanced pancreatic mass encasing all the major vessels, compressing the duodenal wall, causing gastric outlet obstruction, and there was a moderate intrahepatic biliary radicals dilatation. There were few suspicious lesions on a CAT scan, and we did an MRI, which suggested that probably they are metastatic. So this is probably LAPC versus early metastatic disease. CA19-9 levels were very high, 9,000. Biopsy we did from the pancreatic mass was positive for adenocarcinoma. Bilirubin was 5. Alkaline phosphatase was 3 times upper limit. Transaminases were normal. Albumin was on the lower side. Rest all labs normal, no comorbid conditions, young patients, no family history. Dr. Bharat, let me come to you. This is the patient, what I call as double obstruction, typically for locally advanced pancreatic cancer. How do you manage this in your clinic?
Lot of things to take care of. This is a patient with a performance status of 2, so less than ordinary physical activity. You have multiple obstruction. You have a gastric outlet obstruction, and you have a, because of head of pancreas, you have a double obstruction. So probably the first thing is the intent of treatment is palliative. It is liver mets only with a poor performance with a jaundice. So probably in this case, I'll try to put a stent. I think so. That will be a better option being a metastatic disease. First a biliary stent, if possible through PTBD, and then probably duodenal stent. I think so. That will be the best.
How would your ERCP scope go if you have a gastric outlet?
That is what I told PTBD. I told PTBD.
About gastric outlet obstruction.
Because you can't put it. Look, it is a wire. If it is complete obstruction, you don't have an option of ERCP. So you need to think of doing a PTBD, go retrospective, put a stent, probably in a and then do a, if it is gastric outlet is complete or patient is not able to take it, probably for a palliative thing, a duodenal stent or a what we can call a double stent. That is the only thing.
So yeah, for this patient, we did a duodenal stenting first, and then went through ERCP and then did a biliary stenting. Dr. Krupa Shankar, what is your cutoff level of bilirubin? You know, what's the level which you like when you will start? He's young, that you want to start palliative chemo. What's your level?
So hi Viraj. Anyway, nice to see you, mate. Virtually at least. Yeah. So first things, so suppose I have a patient presenting with a very high bilirubin, let's say in excess of 10 or more. I would look at either stenting the patient or doing PTBD and then bringing it down. So I'd be comfortable starting on platinums once it's around between 3 to 5. I'd be comfortable with platinums. I would try and avoid irinotecan, especially if the bilirubin is still more than 3. Once it's less than 3, I would start with a modified dose of irinotecan, let's say around 50%.
So just to get it clear, let's say to start with it is 15 and after a week it is 7. Are you comfortable to start?
No, I won't. I would probably be comfortable once it comes down to less than 5. I would probably, that sort of benchmark. Yeah. And, between 3 to 5 would be ideal. And then, I would look at giving platinums because platinums are generally much more safer. The hepatotoxicity is much lesser. So I would, generally lead in with the platinum and then look at adding the subsequent agents later on once the bilirubin completely regresses.
Dr. Sahu is mentioning that decreasing trend is okay. Dr. Crystal, have you given chemotherapy at bilirubin 7? Let's say it started with 15 and next week it is 7. Would you start?
So I think it depends on how comfortable you are that the patient is having adequate biliary drainage. I think, if we know that the patient has a good percutaneous biliary drain, that they've been stented or they've got open drainage and you've identified that that drainage is good, you could potentially start if the reason the patient's performance status is really declining is due to his cancer. I have given Fulfox in this situation with dose modifications with oxaliplatin at like 65 milligrams per meter squared, and then the 5-FU when a bilirubin's above 5, usually at like 50% dose reduction or 75% of the full dose, and then escalate as the patient's bilirubin comes down. So some of the decision about when to start chemotherapy really depends on how much time you think you actually have, as well as how well you think the biliary drain is functioning.
Viraj, if you see all the registration studies have taken as 1.5 times the upper limit of normal. If you see both the studies, so it becomes 3. 2 is the upper limit. I think 3 is the thing.
I'm talking in the clinics. Okay, Dr. Smita, let me come to you. Let's suppose this patient we have decompressed. Bilirubin is less than 1. The PS has improved to 1. Patient is eating well now, 3 chapatis now per meal. So what's your schema of choice, FOLFIRINOX or Gem/nab-paclitaxel?
So for this patient, if the performance status improves, we'll go with the modified FOLFIRINOX. For the first cycle, maybe omit the irinotecan, add the irinotecan from the second cycle onwards, given that the background recently recovered from the obstruction and hyperbilirubinemia.
Why do you choose FOLFIRINOX over Gem/nab-paclitaxel? Is there any evidence? Just one is superior over the other?
No randomized data to say FOLFIRINOX is superior. If we take the trials individually, it's slightly better OS with the FOLFIRINOX.
Right.
There's some retrospective data to say FOLFIRINOX is maybe doing better than Gem/nab-paclitaxel.
Correct. So yes, Dr. Bharat.
Everything if you compare, if you have a cross trial, you can do the response rates are better, PFS is better, the hazard ratio is 0.54 versus 0.72, OS more importantly is better. If you say, is there a comparison? So in a real life study, yes, we have a comparison, a big Canadian study, retrospective, 1,000 patients, 9.5 months survival versus 6.5. So for all purposes in a metastatic setting, in a fit person without a biliary decompression, we have enough and adequate data to say that in a fit person, FOLFIRINOX is probably better, although it is cross-trial or a real-life study.
Excellent. So that is what I wanted to illustrate to. The Ontario data, what you just referred, showed us 1,000 patient data. Of course, only 500 or 600 were metastatic. And it showed that in that center or in that university data, FOLFIRINOX was better than Gem/nab. So let me come back to Dr. Krupa Shankar. Let's say we want to use FOLFIRINOX. What is your secret recipe? What's the dosage you use in clinical practice? Don't give me the bookish dose. Tell me what you use in your practice. What's the dose of irinotecan? Do you bolus, yes or no? And what's the dose of 5-FU infusion? And leucovorin, yes or no? All these 4 questions.
Sure, great. I'll take them one at a time, Viraj. So I think, like Dr. Bharat was mentioning on the real world data, even if you look at that data, the incidence of febrile neutropenia was higher on the FOLFIRINOX arm.
Only 5.
That needs to be really factored in as well. So you need to have an extremely fit patient with a very good general condition to even contemplate fall FOLFIRINOX. And I usually do modified fall FOLFIRINOX only, which is at a lesser dose of irinotecan. It's around 150 milligram per meter squared of irinotecan. And I mean, like, this is just my practice. I generally don't use LV, and I don't use it once in 2 weeks as well. I tend to do it once in 3 weeks in practice, even though all the trials and guidelines say, you'd have to do it once in 2 weeks, and you would have to have a high dose of LV and the infusional 5FU as well. That's not what I would do in practice. I still do with the 6-hour infusion of 5FU rather than, a 48-hour infusion. So this is what I do in practice regularly.
Great. So, Dr. Crystal, a tough one for you. Modified FOLFIRINOX, we omit bolus 5FU. Is there any evidence that adding leucovorin enhances the infusion 5FU efficacy? Because it generally enhances the bolus efficacy. So, then do we need leucovorin? Because I also have stopped using leucovorin in my practice. What's your call?
So I think this is actually a topic of great debate. We still debate it in the U.S. whether the use of infusional 5FU only requires leucovorin. And I think if you were to sort of poll even U.S. oncologists or even oncologists in my own practice, you would find that some of us will use leucovorin. I tend to use it, but others will not. Typically, when we give high-dose 5FU for, say, esophageal cancer or anal cancer, we don't give leucovorin when we're giving infusional 5FU. So I think that leucovorin is most indicated when you're giving the bolus 5FU, and I think it's more optional in the infusional setting. So I personally do give it, even if I'm eliminating the bolus. But I think that it is not wrong to eliminate it and just use the infusional 46-hour infusion.
Have you gone to 135 mg of irinotecan in your practice, or do you stick to 150?
So my typical practice is to omit the bolus, give the leucovorin, and use irinotecan at 150, and then I typically give GCSF automatically on the day of disconnect for the 5FU. So typically what happens is I have my patients come back in for their 5FU disconnect, and they get disconnected and get GCSF at that point.
Okay, great. Dr. Bharat, let me come to you. Let's suppose in this patient we want to give gem-nab-paclitaxel. What is your recipe? Weekly for 3 weeks, then a 4th week off, or alternate weeks, or what is your
now what I do is I'll start. Gem is something I don't compromise, 1000 mg per meter square. It is a nab-pacli part which I try to modify myself. Now I'll tell you, a patient who is absolutely fit, I may start at 125 mg per meter square, but if you see, this is the only indication in oncology where it is 125 mg per meter square. If you see the lung data, so it is 100 mg per meter square. So most of
the phase 1 data didn't have any difference between 100 and 100.
Yeah, that is what. So what I do is I start my patient mostly on 1000 mg per meter square gem, and what I say in nab-pacli, I give mostly 100 mg per meter square. 125 mg by day 15, most of my patients have become neutropenia. I started by the 3rd dose of the first cycle.
So if you use 100 per meter square and the dose comes 150, so 50 milligrams is wasted? Or
yes, and then now the costs have come down. Maybe 7,200 is the cost of 100. So probably when you see a cost, I waste it, sir. If a patient is fit, at the end of the day, if he can tolerate 125 mg per meter square, but most of the time I come down to 100 mg per meter square by the first cycle, 3rd dose. Regarding those patients who may not be fit, I omit the day 8 also. Now, yes, there is a data, what I said, from the Mayo Clinic where you have omitted the day 8, and they have done a respectively well in terms of PFS also close to 5.5 months and the OS also close to 9 months. So at the end of the day, you have to give the treatment. That is more important. Depends upon the performance status, tolerance, and the toxicity profile. If the patient is fit enough, young, is able to tolerate 1/8-15 with the normal dose, any sorts of problem, gem probably in a full dose, NAB I modified to 100 mg per meter square, that also maybe in 100, what we say, a dose. And if still a problem, then day 115 I give it, every 28 days.
Sure. Dr. Krupa Shankar, let me come to you. Let's suppose on cycle 2, day 8, platelet counts are 80,000. This is typical what we find it when you give gem-nab-paclitaxel for weekly. What are your strategies? Do you delay? Do you use TPO agents? What do you do?
So yeah, great question again, Viraj. So the thing is, obviously, we've all heard about gemcitabine causing thrombocytopenia as well. Number one. So yeah, well, the thing is, in general, sometimes I tend to wait. I tend to skip over the dose of gemcitabine and move on to the next cycle and then treat. And if despite that the platelet counts don't improve, yes, I have used a TPO agonist in practice, thrombopoietin receptor agonist. L-trombopag is some L-trombopag is something that I've used at starting at 25 milligrams once daily. So that's something that I've just used. I mean, like, I know it's not an approved indication for chemotherapy-induced thrombocytopenia, but still that's an off-label indication, and I've used
I'll be honest, I've started using it as prophylactic. Dr. Crystal, I wanted your opinion on that. Do you believe TPOs can be used as a prophylactic agent when we wanted to use gem-nab-paclitaxel? We have a data from Memorial.
Yeah, so I typically don't use it in metastatic disease. I think that there is risk and it's extra costly. And so at this point, if I have somebody whose platelet count is the main driver of the treatment limitation, I would just modify the dose, specifically maybe a modification of the Abraxane as well as potentially a mild modification of the gemcitabine. If you look at the MPAC trial itself, which is the protocol is actually available on the website, and they actually allowed for a dose modification of a platelet count as low as 50 on day 8, with dose modification of gem and Abraxane, nab-paclitaxel, and then potentially re-escalation on day 15. So for some patients, I've actually done that. If somebody I know is pretty fit and doesn't have high risk for bleeding, I have used the MPACT dose modifications based on platelets and neutropenia. But for, say, an older, frailer person where there might be a risk for fall or their performance status is not ideal, I just omit the dose, and then at the next cycle decide if I want to do day 1, day 15, or if I want to modify the dose and just lower the dose and try and get all 3 weekly doses in.
Okay, great. Now, since we are running late, I think so we have to wrap it up. Last question, Dr. Bharat, I want you to comment on POLO. No OS advantage, no improvement in quality of life.
Sir, I appreciate. Sir, I appreciate
What's your take?
our guest speaker has spoken. Sir, I am not convinced. Absolutely not convinced.